Modified technique of ILM autograft for macular hole. Kelly and Wendell reported the first successful macular hole closure with surgery. Nonetheless, there are still some macular hole cases that are refractory to conventional surgery. Recently, Morizani and co-workers have described a novel technique using an ILM autograft to fill in the macular hole and induce its closure, with excellent results. The purpose of the present study was to describe functional and anatomic results of refractory macular hole cases treated with a modified ILM autograft technique. This was a prospective interventional case series study where we included 4 eyes of 4 patients with macular holes refractory to conventional surgery. This is an animation of the surgical technique. We first peeled off the ILM around the macular hole. After that, we also peeled a little piece of the remaining ILM, displaced it under perfluorocarbon fluids, and put it inside the macular hole. At the end of the procedure, we performed an air fluid exchange and used SF6 or C3F8 gas at a non-expansible concentration to induce the closure of the hole. In this video, after performing vitrectomy and detaching the posterior haloid, we perform an ILM peeling around the hole, leaving a little flap or graft attached to the edge of the hole. After that, we shaved a little bit the graft to match its size to the size of the hole. We use some perfluorocarbon fluids to stabilize the graft, and after that we displace it to the center and inside the macular hole with a silicone tip cannula, or as shown in this case, with the tip of the tennis scratcher. Once in place, we finally perform an air fluid exchange, tilting a little bit the eye so the graft was kept in place. We used, as previously mentioned, C3F8 or SF6 gas at a non-expansible concentration to hold the graft in place, and prescribed a semifowler position to the patient for a few days. These are some of the OCT images of the cases we included in the study. In case number 1, we can see on the left side of the slide the large macular hole, larger than 700 microns, and on the right side we can see complete closure after 2 weeks of performing the surgery. These are some other OCT high-definition images from the same patient. In the picture above, you can see the complete closure of the hole, as well as some irregularities of the different layers of the retina, and a discontinuous ellipsoid layer. These findings tend to improve after a few weeks as shown in the OCT high definition picture below. This OCT image of case number 2 at 11th day post-op shows an hyperreflective image in the center of the macula that we believe corresponds to remaining tissue of the graft. This is a high definition image of the same patient 3 weeks after surgery. These findings tend to disappear after a month of follow-up. Case number 3 shows some intriguing findings. You can see in the center of the macula some hyperreflectivity that may correspond to some tissue that is less dense than the tissue around it. This patient in particular didn't improve that much his best corrected visual acuity at the end of the follow-up. This table shows some of the anatomic and functional results. We achieved macular hole closure in 3 of the 4 cases included. All the cases where we achieved the macular hole closure improved their vision at the end of the follow-up, approximately 3 to 4 months after surgery. These results imply that the flap of ILM placed inside the macular hole has the ability to repair the foveal contour. In fact, some OCT studies to detect glial tissue suggest that Muller cell gliosis is essential for macular hole healing. Besides that, Muller cell proliferation is thought to play an important role in producing an environment conducive to the repositioning of photoreceptors that may translate in a better functional outcome also. Maybe this technique will be suitable for cases that nowadays are considered not candidates for surgery, like this one we published in 2011, a giant macular hole secondary to trauma, almost 2000 microns in diameter, with some important RPE atrophic changes. Thank you.